lower esophagus, thereby preventing lower esophageal reflux relaxation, because the lower esophageal reflux sphincter is out of the picture now. But again, what's the problem with this? Well, if you wrap it too tight, patients will constantly complain of bloating, gas, food is getting stuck. And to go back in and reverse this is sometimes tricky. There's about 10 years ago, 3 endoscopic devices came out on the market. There was a lot of excitement, and they haven't panned out. There is now a new device on the market that we are looking into here at GBMC that may be something that we can offer patients in the future. I think that the cost, if it's effective, I mean, reducing the dependence on medicine will be enormous, you know, its impact. Well, so, you know, this leads me to really, why do we care so much about reflux? Why is there so much emphasis on it? Obviously, from the drug company standpoint, it's because these drugs, it's a billion-dollar industry. They're making a lot of money off these medications. The Prilosec has gone generic. It's a omeprazole. Prevacid has gone generic. But still, I mean, these are very expensive drugs. So the bigger problem is Barrett's esophagus. So what is Barrett's esophagus? It's where, due to chronic acid exposure, the lining of the lower esophagus changes to a precancerous form. And the biggest population that I worry about Barrett's esophagus is those patients that don't complain of reflux, what we call the silent refluxer, that doesn't know that, okay, I'm having symptoms and never has gotten checked out and now shows up with Barrett's or esophageal cancer. So what the schematic on the right shows is that the normal tissue of the esophagus, which is the lighter pink, and the more reddish is stomach, should be a nice smooth line, smooth circle. But what you see here is you see these islands of this dark pink tissue, which are over here, and up here, and this is the definition of what we're concerned about, these what we call these salmon-colored patches of Barrett's esophagus. So it's these columnar appearing mucosa of any length in the distal esophagus with a change, which is what metaplasia means. And we classify these that if it's longer than 3 centimeters, it's long segment Barrett's, and if it's shorter than 3 centimeters, we call it short segment Barrett's. And how does this happen? Well, there's several pathophysiologic processes. So one is you have this transition from this squamous to this what we call now columnar. The columnar mucosas, when you look under the microscope of the stomach, they look like cells. These glands are in columns. But you also have this process people have called the intestinalization of the cardiac mucosa. So the top of the stomach is called the cardia. And when it changes by these two pathways, that's what leads to this precancerous tissue. Now, what's the prevalence? Well, about 0.7% of the population overall will have Barrett's esophagus. Well, you can say, okay, that's a very small number of patients that have Barrett's. But when you look at the number of people that have reflux, you know, it's really not that small. 10 to 15% of patients with reflux will have Barrett's, and about 0.3% in those patients who don't have reflux symptoms will have Barrett's. By definition, all patients with Barrett's esophagus have reflux, because obviously that's the etiology. And the mean age of development is about 40 years of age, but the mean age of diagnosis is 63 years of age. And that's the issue, is that, you know, I do these endoscopies on all patients for a variety of reasons in their 30s and 40s, and I'm picking up Barrett's. Why are we picking it up at 63 then? So that's 23 years that have gone by where we've not been screening them, and this is the problem. So 5% of patients will have long segment Barrett's esophagus, and usually their duration of symptoms are about 15 to 20 years. And this is far more important duration than it is severity of symptoms. We know that the prevalence rises in age, and we know that it's much more common in Caucasian males compared to women. We also know there is some genetic predisposition. So they have identified several genes that maybe you know, set you up for a higher risk for Barrett's esophagus and reflux disease. And then really sort of the ultimate question that everyone is worried about is, well, if I have Barrett's, what is the chance I'll get cancer? So adenocarcinoma of the esophagus in general we know is rising. There's two types of, the two most common types of cancer in the esophagus are adenocarcinoma and something called squamous cell carcinoma. Traditionally, squamous cell carcinoma was the most prevalent, but we've now seen an increase over the past 10, 15 years in adenocarcinoma. The overall risk of adenocarcinoma in Barrett's esophagus is about 30 to 50 times higher than the general population. However, most people with Barrett's esophagus will never develop cancer. And so that, again, sets up a lot of controversial questions. The estimated incidence is about 0.2 to 2% per year. And in patients who have high-grade dysplasia, and we will talk a little bit of how we grade Barrett's, the prevalence of invasive cancer is about 12%, which is fairly high. And again, what are the risk factors for cancer in Barrett's esophagus? Well, we know male gender. People have looked at the body mass index, the BMI. So we know that the BMI is greater than 25, puts you at a little bit of an increased risk. Stooped posture. So people have looked at posture because, as you can imagine, when you're bending over a little bit, now you're reducing the surface area from the chest to the abdominal cavity, therefore setting you up for reflux. We know tobacco use is associated with reflux. We know those patients that have decreased heartburn symptoms, so the silent refluxer is at higher risk for the cancer. Those patients that are not using acid suppression, and those patients that have this particular genetic mutation. So again, the controversial question is, why don't we do screening for Barrett's? Well, screening, the definition is applying a simple test, which is fairly inexpensive, to identify those people that are at high risk of cancer or have cancer. Those high-risk patients we've talked about as far as for Barrett's esophagus. And the problem is that in those patients that the majority of patients that we screen with reflux don't have Barrett's. So it's a very expensive ordeal to put people through endoscopies for Barrett's. Now, we are looking at non-invasive tests. One test that people have talked about is we have the capsule. If any of you are familiar with capsule endoscopy, it's a little pill you swallow. It has a camera and a light on it. And it takes pictures every 2 seconds. Well, right now we're using it for the small intestine, but there's a special capsule that's in development looking at the esophagus to screen for Barrett's. And the way we grade Barrett's really is into these three categories, which is those patients that have no dysplasia, meaning no precancerous changes, low-grade dysplasia, high-grade dysplasia, and cancer. And I think another paradigm that shifted is that traditionally those patients that had high-grade dysplasia or cancer, the algorithm was surgery. Well, now through the advent of some new endoscopic techniques that we're doing, these patients are getting endoscopic treatment and not having to go to surgery. But we can talk about that as well. So what are some of the limitations? Well, obviously there's going to be a lot of variability among pathologists. So if you put 3 pathologists in the room, you have them read the slide, each one may say a little bit of a different thing. There's also horrible variability in the terms of the endoscopists and where they sample the area. And this has gotten a lot of scrutiny because there's a very careful protocol that we take when we're surveying people for Barrett's, but if you don't sample the right area, you may miss it. And then, of course, the question that is very tough is how do you distinguish really early cancer from pre-cancer? Well, that leads me to sort of the next segment. Are there any questions so far about Barrett's or reflux? Okay. So traditionally, how do we diagnose Barrett's? Well, we do what's called an endoscopy, which is a scope that has a camera and a light, and we take a good look, and we take biopsies. But we're learning that more and more, fairly archaic way of looking at Barrett's. There's far better technology out there. And these are some of the technologies that have come on the market really in the last 5 years. So what are some of the currently available technologies? Well, right now we do what's called high-resolution video imaging. And right on our scopes, we have a button we can press where we can magnify images. We have another button that we can press, and we can do something called narrowband imaging. Narrowband imaging isolates the area of Barrett's disease from the other tissue and helps magnify it and allow us to look at it. But really, the future of how we're going to be diagnosing diseases in the gastrointestinal tract is this area of what's called confocal microendoscopy, and I will go through that. Some of the stuff on the bottom is still in development, a little more advanced, and I don't think we need to touch on it here. But this is an example of just some simple things. So this is a simple solution that you can spray in the esophagus, and those of you who have never done endoscopy can still tell me where's the esophagus.